Rahim. Hello friends. Today we will discuss about the coronary artery disease part 2, in which we will first define the angina pectoris. Angina pectoris is a clinical syndrome usually characterized by paroxysm of pain or pressure of anterior lobes. The cause is usually insufficient blood flow to the heart. There is a diagrammatic representation of the chest pain which is in angina patient. Types: stable angina, predictable consistent pains that occur in exercise or in exertions and is relieved by the rest. Unstable angina, also called pre-infarction angina, symptoms occur frequently and last longer than stable angina. Pain may occur at rest. Variant angina, also called premenstrual angina, pain at rest with reversible ST segment elevation thought to be caused by coronary artery vasospasms. Microvascular angina, otherwise angina X syndrome, also known as angina X syndrome. Patient have chest pain but does not seem to have blockage in coronary arteries. The pain may be due to tiny vessels that feet, heart, arms, neck are not working properly. Silent ischemia. Objective evidence of ischemia such as electrocardiographic changes with a stress test, but patient report no symptoms. Angina pain feature: squeezing, burning, tightening, aching across chest usually start behind the breastbone. They often spread to the neck, jaw, arm, shoulder, throat, back, and or even teeth are also feel pain. Attack of the stable angina lasts for 1 to 5 minutes. There is a diagrammatic representation of the typical distribution of the referred pain in angina patients. Myocardial infarctions. Myocardial infarction refer to a dynamic process in which one or more regions of the heart experience a severe prolonged decrease in oxygen supply because of insufficient coronary blood flow, subsequently necrosis or death to the myocardial tissues. Heart attack, also known as heart attack. There is an area of infarction shown in the diagram below. Classification based on pathology: transmural, associated with atherosclerosis involving a major coronary artery. It can be subclassified into anterior, posterior, inferior, lateral, or septal. Transmural infarct extend through the whole thickness of the heart muscles and are usually a result of complete occlusion of area blood supply. In addition, on ECG, ST elevation or Q waves are seen. Subendocardial, involving a small area in a subendocardial walls of the left ventricles, ventricular septum or papillary muscles. The subendocardial area is particularly susceptible to ischemia. In addition, ST depression is seen on ECG. Etiology: reduced blood flow in the coronary artery due to atherosclerosis, increased oxygen demand, and decreased oxygen supply. Complete occlusion of the artery by emboli or thrombus, sudden narrowing of the coronary artery, vasospasms, acute blood loss, anemia. Risk factors: we have I have already told that in coronary artery disease we have risk factor into two: non-modifiable risk factor or modifiable risk factor. In non-modifiable risk factor we have family history of premature coronary artery disease, which means the inheritance patterns, and there is a predispositions of male towards the myocardial infarctions. Modifiable risk factors are smoking or other tobacco use, diabetes mellitus, hypertension, hypercholesterolemia, hypertriglyceridemia, including inherited lipoprotein disorders, dyslipidemia, obesity, sedentary lifestyle, and lack of exercise, psychosocial stress. Clinical features: chest pain. Pain in is only one part of body, or it may be moved from chest to arm, shoulder, neck, teeth, jaw, belly areas, or back. The pain can be severe to mild. It can be feel like a tight band around the chest, bad indigestions, something heavy sitting on the chest, squeezing or heavy pressure. The pain usually lasts longer than 20 minutes. Rest, a medicate called nitroglycerin may not completely relieve the pain of a heart attack. Symptoms may be also go away and come back. Other symptoms of heart attack or myocardial infarction can include anxiety, cough, fainting, lightheadedness, dizziness, nausea or vomiting, palpitation, feeling like your heart is beating too fast or irregularly, shortness of breath, dyspnea, sweating which may be very heavily. Diagnostic test. A doctor or nurse will perform a physical exam and listen to your chest using a stethoscope. The doctor may hear abnormal sound in the lungs called crackles, a heart murmur, or abnormal sound, a fast or even uneven pulses. Blood pressure may be normal or high. Electrocardiograph to look for heart damage. A troponin blood test can heart tissue damage. This test is a confirmatory test. Coronary angiography may be done right away or when a patient is more stable. This test uses a special dye or X-rays to see how blood flow through heart is going. Echocardiography, exercise stress test, nuclear stress test. Management. Pharmacological medication given to treat a heart attack include aspirin, reduce blood clotting, thus helping maintain blood flow through a narrowed artery. These drugs, also called clot busters, help dissolve a blood clot that's blocking blood flow to your heart. Superaspirin. These include medications such as clopidogrel or other called platelet aggregation inhibitors, such as heparin, to make blood less sticky and less likely to form more dangerous clots. Heparin is given intravenously by injection under your skin, is usually used during the first few days after a heart attack. If chest pain or associated pain is greater, you may receive a pain reliever such as morphine to reduce discomfort. Nitroglycerin. This medication used to treat chest pain, angina, temporarily open arterial blood vessel, improving blood flow to and from the heart. These medication help relax blood muscles, slow your heartbeat, and decrease blood pressure, making heart job easier. Beta blocker can limit the amount of the heart muscles and damage and prevent further heart attack. Thank you very much.